UTI, urinary tract infection. Today, we'll talk about cystitis, pyelonephritis, and prostatitis. Pathogens causing UTI. The most common one is E. coli, and the next common one is Staphylococcus saprophyticus. UTIs are more common in women because the length of urethra is shorter in females compared to males. So at the entry of urethra, the bacterial colonization begins when there is some happenings in urethra, like intercourse, and loss of bacteria flora. For example, using spermicide condom, urinary tract is more vulnerable from the pathogens, so it is more likely to cause infection. So cystitis is located in the lower urinary tract, such as urethra and bladder. This is the most common one, and when peeing, it can cause pain and increase the frequency of peeing. This is usually treated by trimethoprim and nitrofurantoin. Next one is Pylon Nephritis. This is in upper urinary tract, near the kidney. So sometimes pain from kidney, and it includes some fever, nausea, and vomiting. It is really different from cystitis because it is near kidney. This is treated by amoxicillin plus clavulanic acid or IV amoxicillin plus gentamicin. And prostatitis is more common in men. It is treated by ciprofloxacin or dorfloxacin. So there is two cases, uncomplicated versus complicated. Uncomplicated case is for non-pregnant women, so there's no resistance mechanism, and it includes men. So 80% occurs due to E. coli, and 10% occurs due to Staphylococcus saprophyticus. The complicated case is more resistant infection, and there's high failure risk. It includes the pregnant woman case. So 30% occurs due to E. coli, and Proteus mirabilis, Enterococcus faecalis, and Klebsiella pneumonia are included in this case. This is complicated and it has higher risk to develop into sepsis, so it should be handled with more severe medicines. Let's look at cystitis. Cystitis, it is managed simple with oral antibiotic or non-pharma solution. In the beginning, it is usually treated by narrow spectrum antibiotic. So as you can see, the picture from Sutta Puranwang, this is for commoners. Cystitis for commoners, which includes men and non-pregnant women. The first line is trimethoprim for 3 days or nitrofurantoin for 5 days. However, if this is not working, then we can use cephalexin for 5 days instead. For the complicators in cystitis, the first line is nitrofurantoin. Second line is cephalexin. However, note to avoid using nitrofurantoin when pregnancy is over 36 weeks because nitrofurantoin can cause baby jaundice or hemolytic anemia. So nitrofurantoin 5 days for cystitis because it is bacteriostatic in low concentration and bactericidal in high concentration. It can be absorbed well by mouth and first-line therapy for acute cystitis. Usually used as first-line in uncomplicated acute cystitis, because it kills E. coli well. However, it does not reach MIC for Pseudomonas or some Klebsiella. Side effect is nausea and vomiting, and it can be reduced when it is taken with food. Next, let's check out the pyelonephritis in upper tract. So this is in upper urinary tract next to kidney, and it is infection in that area. So sometimes pain from kidney plus some fever, nausea, and vomiting. It is really different from cystitis. It is treated more commonly by IV antibiotic, and it has a broad spectrum antibiotic is usually chosen in the beginning. First line is oral amoxicillin plus clavulanic acid. Second line is amoxicillin plus gentamicin. Pylon Nephritis in pregnancy IV. So we use gentamicin plus amoxicillin or gentamicin plus ampicillin. So initial therapy includes gentamicin, but note that we do not use gentamicin for more than 72 hours. So note caution for gentamicin. It is bactericidal protein synthesis inhibitor. So when you finish patient's urine culture, it'll tell us what the bacteria exactly is. So we use it for first 72 hours, then we change into beta therapy, which is empirical. It has a broad range of some gram-positive bacteria and gram-minus bacteria, including E. coli and Pseudomonas and Proteus. Side effect is that it can cause nephrotoxicity. Lastly, let's check out the prostatitis in prostate in the lower tract. So prostatitis. So when man has UTI, we can suspect prostatitis. Here again, E. coli is the most common pathogen. It is because E. coli has membrane that can stuck into urinary tract cells. Note here, first line is oral trimethoprim for 2 weeks. Second line is oral cephalexin. So we use trimethoprim for the first line because it enters prostatic fluid and achieves higher prostatic concentration than in plasma level. So here there are some medicines that we cannot use because of prostatic fluid, and we'll discuss it later. And if patient is resistant to above, then we can use the ciprofloxacin for 2 weeks or dorfloxacin for second line for 2 weeks. Caution for dorfloxacin for prostatitis: do not use this with iron supplement. Take dorfloxacin and iron supplement should be separated by 2 hours because they have some interaction problem. Dorfloxacin is second line because it has broad spectrum and it can be related to antibiotic resistance. Also, we do not use nitrofurantoin for prostatitis. Why? Because nitrofurantoin cannot cross the prostate. This is inappropriate treatment. To treat for the first line, it is trimethoprim for the prostatitis. Oral is the first line. If it is severe, then we go 4 weeks. If it is not severe, we go for 2 weeks. And there are counseling tips to prevent UTI. First, drink a lot of water because bacteria will go outside from body by urination. Second, wipe from front to back, not from back to front, especially women after peeing. So wiping from front to back prevents bacteria in rectal area spreading out to different zones in the body. Third, empty the bladder after intercourse. Fourth, do not use spermicide condoms or diaphragm.